Good afternoon, everyone, and thank you for joining us for today's webinar, Advancing Emotional Well-Being in a Multicultural Aging Society, Practices and Programs. Today we are joined by Nancy Wilson to discuss this very prevalent issue among aging populations. After today's webinar, my name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and the Aging. Some of our goals here is to provide training and technical assistance to health centers and community members serving underserved and aging populations. So we do this through free forms of training and technical assistance, such as webinars, through regional trainings, manuals, toolkits, and the like. After today's webinar, participants will be able to describe practical approaches and tools for recognizing and assessing mental health and substance misuse in underserved older adults, low income, and ethnic and racial minorities. Also, participants will be able to discuss how culture influences approaches to screening and addressing mental health needs of different cultural subgroups within the aging population, and participants will be able to identify at least 2 evidence-based practices for addressing these disorders in older adults. Very briefly, some data on older adults in the United States. Of the minorities in the U.S., about 42% of those 65 and older are African American. And you see that the Hispanic population is beginning to catch up with the African American population. We also have a pretty strong Asian Pacific Islander population. All of these are very crucial to understanding how to address mental health issues. A lot of cultural aspects will be a part of your programs and services. Also, some of the common conditions older adults in America face are anxiety, forms of dementia, and mood disorders. So older adults will suffer from these conditions, and it may prevent the services and the programs that you offer. Also, older adults are at risk for substance abuse and misuse, and it's up to healthcare providers, caregivers, and other members of the care team to address these issues and to appropriately screen older adults for these conditions. Here are some other resources, and Nancy will definitely go into more detail about the resources that are offered and out there. Nancy Wilson is an assistant professor in both the geriatric section of the internal medicine department at Baylor College of Medicine in Houston and Baylor Center for Medical Ethics and Health Policy. She is the assistant director of program development for the Huffington Center on Aging and associate director of the Texas Consortium of Geriatric Education Centers, both at BCM. Wilson is also a clinical instructor of gerontology at the University of Texas School of Nursing in Houston, and she received her MA in Social Service Administration from the University of Chicago. I will go ahead and turn the presentation over to Nancy and also announce that this will be recorded and made available to all attendees after the webinar.
Thank you, Rachel, and good afternoon, everyone. I hope wherever you are, you're anticipating spring in a positive way. It's my privilege to spend some time talking with you and allowing some time at the end of this session to hear from you about this very important topic as we see the aging of our population. I would like to acknowledge some key contributors both to my development in this field but also to some of the information you're going to hear from me today. In particular, the Substance Abuse and Mental Health Services Administration, in collaboration with the Administration on Aging, have put together a number of resources which I will highlight how you can access throughout today's webinar. And I am drawing upon some of the work from that effort. I also am very grateful to collaborating colleagues from several arenas, my home team here at Baylor College of Medicine and the Houston VA Health Services Research and Development Center, the National Council on Aging, Center for Healthy Aging, been a collaborator and leader in this work along with SAMHSA and AOA. The University of Washington, the home of some of our strongest evidence-based practices for older adults in the area of depression. And then last but not least, the very committed state and community agencies around the country and primary care practices that are addressing aging and behavioral health needs. So as what I want to do today in the time that we have is provide a little bit of a rationale for why it's extremely important that health centers, with all the demands that come in their doors, make sure to address emotional well-being as part of that. Try to talk about some of the more practical approaches and tools that one can embed in day-to-day practice to assess mental health, particularly amongst underserved populations. Reflect a little bit on how we need to be mindful about how culture influences how we approach the process of screening and addressing mental health needs, and then highlight some further resources in this somewhat fast survey that you can follow up with if you want to get more training and perhaps pursue implementation of some of the practices I'll talk about. So first, I just want to acknowledge not being able to know exactly who's on the line with me, that each of you comes from very distinct communities where you may have a diverse array of services and capabilities in different organizations within your community. And obviously, as Maurer and Druss remind us, anytime we start to think about how we're going to address behavioral health issues, we have to, if we're thinking about it from a population-based approach, we have to be mindful of a number of these issues. So what's the workforce that we have available to address these issues? How prepared is our organization to support attention to behavioral health needs? What are the financing and other reimbursement factors, because that's obviously an influence on what we're able to do. And then what are the specific needs of our population in whatever diverse circumstances we find? Who are we serving and what do they need? And what are their preferences for how to receive attention and who to work with around behavioral health needs? These are all obviously key factors. But regardless of context, I think I'm always thinking about this issue from two vantage points. As a leader, somebody who may have responsibility within a service delivery setting, what role can I play in advancing attention to these issues? Who are partners that I need to be thinking about, not only within the four walls in which we all work, but also within the broader community? Are there settings that have different relationships than I have? And then obviously we want to use our best knowledge to identify the effective approaches that I think are going to best address the needs and preferences of my population, but also the capacity of the organization that I'm playing a leadership role in. And then many of us also function as individual practitioners where we're working day to day with individuals and families. And so I'm always trying to advance my knowledge and think about how can I improve my ability to identify and depression and anxiety symptoms. What can I do that's going to empower the person I'm working with and expand their knowledge and skill and self-care actions? And then what's our ongoing effort to try to educate not just people in our workforce, but in our broader community, because these are all culturally bound social issues as to whether or not we get attention to emotional needs within our work, and how do we educate families, individuals, and colleagues to be mindful of this topic and what we can do. So I'm going to first start off to just, as part of the rationale, really build a case briefly, and you have lots of ways of following up on this, and Rachel got us kicked off nicely about being mindful about numbers. And I think most of us recognize that depression isn't a normal part of aging or any life stage. It's a medical problem, and it affects lots of older adults in a number of different settings. And I think here we just see that if we're just talking about major depressive disorder, even as many as 1 in 10 people who come through a primary care clinic door can be diagnosed with major depression if that's addressed in that setting. But even in the community setting where we have many aging service providers, we have individuals receiving services that, again, were they to be adequately evaluated, would be identified as having a major depressive disorder, and this is certainly higher in those clients receiving long-term supportive services in community settings. And then as we think about the nursing home environment, we know that that's also a population with significant burden from depressive major depression. But I wanted to underscore here that it's not only major depression which creates disability in older adult populations, and what we often think of as minor depression or subsyndromal depression is equally disabling, and you can see the rates there are significantly higher for clinically significant and disabling depressive symptoms. So as we think about depression as in the context of all the other issues, chronic conditions that we know we're charged with addressing, I always remind myself that depression as a chronic condition is costly, it's disabling, and it's deadly. We know that depression can impair, in particular, all adults, but in older adults' ability to function and enjoy life and to be able to address other health conditions. What can I do to take care of my diabetes or my heart disease? If my mood is low, I'm lacking energy, I'm not able to sleep, and I'm not able to take initiative around things. It has huge impact on the most basic types of self-care and daily living activities. And we also know that it has huge impact on recovery from disease and day-to-day management, and is the #1 risk factor for suicide, which is the ultimate price of untreated depression. But I think oftentimes we lose sight of the fact that in addition to these personal costs, depression has a huge societal cost, in that as an individual with clinical depression, my healthcare costs, the treatment of other conditions, may be as much as 50 to 100% higher were I not to have that condition. So we see great evidence of increased morbidity, mortality, inability to follow medical routines, and ultimately to recover. So I think this graph probably tells the story quite clearly when we think about the experience of a heart attack and look at survival rates or death rates for those persons who were assessed as depressed versus those people who weren't. You'll see that that depression has a significant impact on reduced survival. So you see that the small percentage of people who experience death without depression versus with depression, pretty striking. So as we all recognize, suicide is a worldwide phenomenon, that suicide rates increase in later life around the world, and that's particularly striking, and it's still true in our country, even though rates are not as high as they once were. We have a growing number of older adults, so the absolute numbers of older adults committing suicide successfully has increased. And one of the things we want to underscore is that when you look at the age 85, which is the fastest growing of subgroup of older adults, their successful suicide rate is 2 times the national average. As we may appreciate, the rates are higher in men compared to women, and in the white population compared to African American and other non-white groups. And this is particularly concerning as we recognize our challenges in reaching men in treatment. So on the bottom of the slide, you see the statistics about how many older men had seen their primary care provider on the day of suicide. So 1 in 5 had actually had a medical encounter on that very day. 40% had seen their primary care provider within a week, and 70% had seen within a month. So clearly these are missed opportunities to address this issue that we need to think about what we can do as we seek to decrease the suicide rate amongst all ages, but particularly amongst older white males who have the highest rate. And one of the things to note about that is that that older adults who attempt suicide are much more successful compared to other populations. They have a greater likelihood of having a lethal attempt. And other than restriction of lethal weapons, addressing depression so far has been identified as the #1 way to address this. We oftentimes don't recognize that anxiety is also a major behavioral health issue in our aging population, and here you see the statistics about the community prevalence of anxiety. As we know, anxiety is not all generalized anxiety. The most common anxiety disorders amongst older adults include phobias and PTSD, but generalized anxiety is the most prevalent, and we know that anxiety is also extremely even more prominent in when we look at older adults who are receiving care within a medical setting and in general, and then persons with chronic illness have an even more frequent diagnosis of an anxiety disorder, including generalized anxiety disorder. And I think that although depression and anxiety often overlap, we do know that anxiety can be the dominant issue in many of our older adults and has not always been recognized, partly because they've never had a lifelong problem addressed, and so don't recognize that this is a challenge as they age. So similar to depression, anxiety has a huge impact on function day to day, and this is even when we control for those people who have both a coexisting depression and anxiety diagnosis. So we see lots of folks who have difficulty with functioning in terms of physical health status. Two common areas which also we see have to do with people withdrawing due to a fear of falling. So if I'm anxious and I've fallen and I'm worried about falling again, I start to be less mobile, I start to socialize less, and that creates increasing disability. Another example of a common limitation posed by anxiety has to do with inability to bathe, again tied in with this issue of falling. Falls often occur in the bathroom, and so we see people really limiting their day-to-day quality of life and function due to anxiety. We also know that anxiety impacts memory, it impacts cognitive functioning, and can be a feature of the experience of dementia. And so again, other ways in which functioning may be affected when I'm not able to remember or take action due to that. And then like depression, anxiety has a huge influence on service utilization, frequent calls to the medical office, or seeking emergency room services that perhaps could be addressed where their anxiety attended to. And then in large epidemiologic studies, we also do see increased mortality when we look at the presence of an anxiety diagnosis. So for those of you who are working with underserved populations, I know you will be quick to say, well, depression and anxiety are not the only thing we see together. Usually this is taking place in the context of a whole range of other issues. And so we have a growing population of persons who may be experiencing economic security, other social stressors due to migration, due to loss, due to concerns about other generations. We have many grandparents who have responsibility for family members, and that creates social stress. So we have a whole host of issues that are all often in play in the presence of someone who may have clinical depressive symptoms or anxiety. And so it probably wouldn't surprise you then to look at these lists of things that are risk factors for who should we be mindful of when we're seeing somebody in a clinical setting that might be at risk of depression or anxiety. And again, we talked about the role of medical illness, particularly chronic medical conditions, which often can be associated with pain, and we know that pain and depression are like twin sisters in terms of the expression of those feelings, and then effect on cognition, as we talked about, and a whole host of other issues. So when we're thinking about who is at risk and who we might need to have high suspicion of these disorders, these are some of the things that come to mind. And then, as we've said, among the risk factors for suicide in older adults, depression being the most major one, but other things that we may see in a clinical setting as well. Someone who has significant general medical conditions, and particularly when we see, when they've been looking at studies of suicide, recognizing that people who may have new and serious diagnoses, perhaps this is an opportunity which we should be particularly intervening. So someone who learns that they have cancer or poor prognosis or a dementia diagnosis, we need to be particularly mindful of looking at their risk for depression and anxiety. And then, of course, access to lethal means being something as a safety concern that we always have. So we have these very prevalent conditions that have significant disability that we know they're drivers of healthcare utilization and overall costs. So on the balancing side of that, over the last several decades, we've done a good job, the field of mental health across several disciplines, in establishing that we do have positive evidence-based practices, so that we know there's treatment out there and approaches that can be effective. We know this is true in terms of integrated service delivery in primary care. We know there are a growing number of mental health and substance abuse outreach models with good evidence for improvement in those issues. We know that there is some evidence for work going on in long-term care settings through mental health consultation and treatment. There's strong evidence for some of the multidimensional family caregiver support interventions, and then primary evidence, particularly as it relates to depression and anxiety, are in the area of a number of established psychological and pharmacological treatments, with the most the strongest evidence being for things in the realm of cognitive behavioral therapy, but also problem-solving therapy, interpersonal therapy, and briefer and briefer versions of those are providing some good outcomes that give us some encouragement. So we've got prevalent issues, but we have some things that we can respond with. That said, despite my enthusiasm for the existence of evidence for a variety of models, both for the medical setting and the community, we know there's still a huge gap between what we know and what we do. And the Institute of Medicine affirmed this in their report released about 1.5 years ago, reporting, look at the disparity between adults with a mental health or substance abuse disorder that were receiving any kind of treatment. And that wasn't necessarily from a medical setting, wasn't necessarily from a specialty mental health setting. You see the gap there. Only 1 in 10 of adults 65 and older, compared to not a great rate, but much better for adults below the age of 65. But the difference is particularly striking when you look at comparing what the experience of older adults with in terms of getting specialty mental health services, so that there's a great difference between only 1% of all older adults were receiving specialty mental health services. This means from a licensed clinical provider in an area of mental health. So I'm sure, again, you could all say, well, I know some of the barriers, I know why that doesn't happen. And we need to start with the client and or the patient, the person that we're concerned with. We know there are lots of barriers that come from stigma around behavioral health issues. You know, I'm not crazy, doc, I'm not crazy, or I'm not a weak person, I have my faith, and I'm not supposed to feel like this, so I'm not going to tell you that it's a problem. Or some people may recognize that they have low energy, that they have low mood, but attribute it to normal aging or to their diabetes and don't have much faith that it's something that they could be reversed through treatment. We know there are a lot of provider barriers. Not all of us have had training in working with older adults, and particularly around mental health issues. We also know we have a lot of expectations of what's supposed to happen in primary care. So our overall concern obviously is how do we overcome some of these barriers, and how do we get the care to the person or the person to the care, and we know some of those limitations are also tied into how we finance services. We still have disparity in the area of Medicare in terms of addressing mental health issues for older adults compared to primary health care issues. So I want to pause here and talk about another important dimension, I think, an oft-overlooked barrier that we have having to do with cultural dimensions of what we have in terms of evidence-based models. And so first, I think we can all recognize that much of the evidence and many of the tools that have been validated for use with all age groups, particularly older adults, are often not developed with diverse populations. So we begin evolving evidence in settings where we have a predominantly English-speaking, sometimes much more economically advantaged group of individuals who can participate in clinical trials, and so we don't have a lot of evidence in how they can always be culturally, linguistically relevant. We also know that culture operates at a lot of different levels. It's not all about our heritage, and there are a lot of different dimensions to culture. And so I think particularly in light of what we know are significant disparities, that older adults are undertreated for depression and anxiety, but persons of ethnic and racial minority status are particularly undertreated, we need to be highly sensitive to issues of culture. And so what are the different dimensions? And I've just listed a few of the more commonly recognized ones, but race and ethnicity, we may have come to hold a certain view of feelings and emotions and how they are to be expressed or not expressed, or who they are to be talked about with. Geography can have a huge role in all this. We see differences in rural versus urban populations, or areas where maybe there's more attention to physical work over cognitive work. So lots of different experiences around what your life experience has been. If you associate mental health treatment with long-term hospitalization, as is true with many of our old populations, then one may be very reluctant to have any interest in talking about feelings or seeking help for them. Religion has a huge view and how plays a role in how we view the world, and whether or not our faith would support us in seeking help. And then other factors around income and sexual orientation obviously play a role, and perhaps you can think of other dimensions to comment on. But so these are all aspects of culture that may influence how people respond to evidence-informed interventions that may not have been developed within their culture. We also know that groups place very different stressor experiences. How did they migrate to our country? What are their economic circumstances? How comfortable are they in mainstream culture, or are they feeling very socially isolated? And just to give an example, in my experience in working with Chinese American older adults with a couple different communities, both here in Houston and in Chicago, we began to realize that how Confucian tradition views the relationships of the mind and the body is very different than traditional predominant Western view. Also that culture may influence how we think about who we're to talk to these feelings about. And so in terms of working with Chinese older adults, it's been much easier in settings to focus on talking about somatic symptoms of depression, appetite and sleep and other issues about other somatic symptoms, as opposed to them endorsing more emotional dimensions of depression, the sadness or the blues. So likewise, is it going to be shameful in the view of my family if I accept this help? So sometimes we may need to think about how we address issues in the context of meeting other needs that may be more acceptable to the family. So someone getting services through a community center that's helping them with income or employment or social activities may be more acceptable than the notion of, are we going to ask mom to go to a mental health center? So these are all kind of examples of how culture may play a role in how we present or where we provide services. And so I think as we are in community settings and health settings, perhaps there is a location where there is already an established service environment within a trusted community that we can think about reaching and providing services there beyond the clinic doors that maybe feel less comfortable. So I think, as we all can appreciate, that clients of all ages, but particularly older adults who have long established patterns and cultural beliefs, may be more likely to accept and pursue help that fits what their preferences are, and we're going to need to understand how they view what's happening and not just rely upon how we view their answers on a screening tool. So how do they think, how are they viewing their problems, and what actions are they willing to consider? And we see differences in how individuals view medication versus non-medication treatment in the same regard. There may be some cultures, some individuals where they're much more comfortable with a medical approach, and others where there's much more mistrust of medical providers given past history. So one of the things that that becomes important is for older adults, particularly older adults of diverse backgrounds, we need to think about what are the variety of points of access where they may be more comfortably able to address this multiple set of problems they may have. So if I'm coping with if I'm experiencing depressive symptoms but also have economic difficulties or social isolation, there are settings where we know we have great opportunity to reach and engage older adults and helping to identify what their behavioral health needs are. And so this is just a diagram shared through the SAMHSA work by the scientific director Steve Bartels that reminds us all the different settings where there may be opportunity to reach older adults of different backgrounds and address their multiple needs. And I think that much of the action and some of the models I'm going to talk about are not focused within the mental health services setting, but rather the majority of behavioral health services is currently delivered through primary care, but there's great opportunity within community settings to reach older adults and help them address their needs. And I think this is particularly important in light of what the Institute of Medicine has highlighted for us, and that is, in the words of this New England Journal article, we have a silver tsunami, a growing percentage of numbers of older adults in mental health care, and an absence of a workforce that is prepared to address these needs. So currently we know that we already have an inadequate supply of clinicians who have been trained, especially for work with older adults. We're not doing an adequate job in addressing these needs now, and we have an expanding population. So the IOM committee came out with strong recommendations that we expand the training of community service providers in some of the settings that I've highlighted on the prior slide in doing evidence-based approaches, and that we look at how to embed screening and brief interventions in current roles of these individuals, and that we think about prevention strategies. So I want to take a minute to talk about what are some of the models with the most evidence, and they in fact align with much of what the Institute of Medicine has recommended. The impact model, which is a long-standing collaborative care model, strong evidence now going on in over 30 states around the country, introduces the role of a depression care manager, and this individual can be of a variety of different backgrounds, sometimes nursing, sometimes other sometimes psychology, and not always degreed personnel, who work in collaboration with the primary care physician and a consulting psychiatrist to help look at medication treatment, to do screening, to look at medication treatment, and to offer brief behavioral interventions such as problem-solving therapy. And the impact model may be something that, because I know many of the collaborative care efforts have been done in federally qualified health centers, that you may see have already had exposure to. If not, I encourage you to get on the website. They have a strong implementation platform, training tools online, and can be of great assistance in thinking about how to integrate this. Likewise, within the treatment area of anxiety, we know that many of the approaches for pharmacotherapy and psychotherapy have been in place for some time, but there's a growing number of approaches that, like the impact model, are looking at, can we introduce someone with lesser clinical background to work with a team to provide a treatment for anxiety. And so in a very recently published article, we have evidence that lay providers can deliver effective cognitive behavioral therapy for older adults with adequate supervision, and that this delivery can involve not just face-to-face sessions, but delivery of skills over the phone. And so this kind of just gives you a flavor for what is incorporated in that model. I think increasingly, as we look at the capacity of non-clinicians to be trained and supervised to do this delivery and can use technology, we can see the opportunity to kind of spread this work. And so these are just a summary of the findings that, in fact, this study looked at comparing the ability of baccalaureate level providers with training to expert providers, and found that, again, with adequate training and supervision and a good model, that they could successfully achieve positive outcomes and positive response rates, both for anxiety, depressive symptoms, and insomnia. So one of the things that we want to think about, and why it's important to think about these opportunities to integrate approaches in primary care, is that it helps us lessen the stigma. People don't have to go to a specialty setting, and it also gives us some natural opportunities to identify older adults with depression and anxiety. And I think we all can recognize that the Affordable Care Act is giving us some key opportunities to do this as we introduce care coordination. Why not incorporate screening into those roles, or as we pay more attention to patient and family support and referral to services. The exciting news is on the Medicare side, we're seeing improved reimbursement for care coordination, so perhaps some of these collaborative care roles where we introduce people addressing anxiety and depression can be included in that. But I also want to underscore a key opportunity to normalize the importance of behavioral health issues being addressed in healthcare through the Medicare annual wellness visit. And these are some of the features that are required in that area. So in your setting, are you taking advantage of the opportunity to get Medicare reimbursement, not only for a Medicare annual wellness visit that can be done by a non-physician, as long as the physician is part of that supervising practice, but also can get reimbursement for screening for depression by certain clinical personnel. And I think these are key opportunities to introduce some of what we know are the effective screening tools for older adults. And so I want to just highlight these and acknowledge that several of them are available in various languages, and and that for depression, the PHQ-9, the geriatric depression scale, have been effectively used both as self-report interview tools, but also as part of a packet that a patient or client can do in another setting. Likewise, there's the GAD-7, which is similar to the PHQ-9, looking at issues of anxiety. Here's the example of a PHQ-9. Many of you may have seen this before. It allows us to ask questions and score to determine a level of depression severity, and many of the models rely upon this to make step care decisions, who needs to get further evaluation, or how is someone's symptoms improving or not as they get help. I want to tell you about a very useful online training resource for those of you who don't have background in training in the PHQ-9. There's an excellent set of video vignettes and role plays that step people through how to get comfortable with having these conversations. And I think this is where issues of culture may really come into play as well. We've seen in many of our groups around the country where it's important to think about how do we introduce this tool, how do we have conversations about it, and in some communities they've even determined that it's effective to change the order of the questions if they're going to be successful in doing this. So don't start off with asking questions about mood and sadness, but start off by asking questions about sleep and eating and more somatic symptoms of depression. Here's the GAD-7 tool, and again, something that can be done in an interview format or can be completed by person as a self-report tool. So we talked a little about programs that are reaching people in the primary care setting. I want to briefly highlight models that are available in many but not all communities around the country where older adults are being seen through service delivery done by community-based agencies. So they may or may not have been had their depression recognized in a clinic setting, but through a community program that incorporated a PHQ-9 or a geriatric depression scale into their service delivery, they identified an older adult who might be willing to be seen at home. And the PEARLS program, which you can get more information about at the website listed below, is done in a client's home over multiple sessions using some pretty standard adaptive behavioral strategies, problem-solving therapy, activation, and pleasure event scheduling. And here you'll see a place where there are PEARLS, trained PEARLS counselors around the country, and there's other information on the website there. Another model that I've been actively involved with is the Healthy Ideas program, Identifying Depression, Empowering Activities for Seniors. This program was specifically developed to embed attention to depression within ongoing service delivery by case management or social service providers, and this website shows where you can get more information about the Healthy Ideas program. Like PEARLS, it's set up around a case management model using existing staff that have relationships and are already seeing clients in their home and have components very similar to what might happen in a primary care environment, except for here you're focusing around screening, education, referral linkage, and then using very simple behavioral activation approaches to help people address their depressive symptoms. And again, Healthy Ideas is being done around the country in multiple states, often through community-based aging service providers. So perhaps as a healthcare setting, you can think about what are the settings in my community that might be able to offer this service. And again, because people are already getting help with transportation, with finances, with housing issues, they're often more comfortable in talking about issues of mood with this person that they have a trusted relationship with. So I've gone through quickly a series of resources that you may want to drill down and get more information about. I'm trying to summarize some of them here. Within the issue brief series, there's several recorded webinars and other information about specifically behavioral health issues and substance issues in older adults. And so I encourage you to get online and access those because they can talk about things in a lot more detail than I've been able to go into them today. And I also want to acknowledge that due to shortness of time, I wasn't able to address the alcohol misuse and abuse prevention issues. But there are brief intervention models for this, and this issue brief and the accompanying webinar that you can access on the website that I highlighted in the last slide may be very useful for those of you looking at how to address this within the healthcare setting. Again, the Medicare Wellness Visit creates an opportunity for us to think about how to have this become part of regular prevention attention in the primary care environment so that we can begin to do some education, because this is one area where there's often lack of knowledge about what is an appropriate way, what should be appropriate patterns of alcohol use, or who could I talk to if I think I'm developing some problems around pain medication. So we've done kind of a quick survey. I'm very interested in getting reactions, comments, and specific questions about some of the models and issues that I've raised. So Rachel, let me just turn it back over to you.
Okay. Thank you, Nancy, for your presentation. Mental health is just so broad, and even talking about mental health and aging, and as you said, we didn't have time to get into alcohol misuse, but I'm sure somebody will probably pose a question about that. But the wealth of information that we have, the resources you provided was excellent. So in order to ask a question, please look at your toolbar and type in your question, and I'll get that over to Nancy, and she'll be able to answer that. So while we wait for some questions to collect in the queue, I just have a few announcements to make. So visit our website, healthintheaging.org, for more resources. We also archive all of our webinars, so in the event that you missed another webinar, because we have had several on mental health issues, on other things concerning older adult populations, just check out our website for that. Also consider joining our mailing list in order to receive some of our resources and updates from HRSA as well as other agencies. Follow us on Twitter. We tweet a lot. We just recently went to the American Society on Aging meeting in San Diego, and we were tweeting and connecting that way, so definitely connect with us through social media. And also, our archived webinars are on our YouTube channel. And then our upcoming symposium, which will be June 9th in Alexandria, Virginia, will feature topics such as mental health and aging, screening models, quality care, and other interventions and evidence-based programs and services. So let's go ahead and open up the Q&A. So first question. Let's see. Is there any evidence-based practices from faith-based interventions?
Well, thank you for that question. So let me see if I am on the same line of thinking. So currently, I think in the past we've had oftentimes professional training that there's certain topics that you avoid, and faith being one of them. And I think it's exciting to see that over the past several decades, the recognition and appreciation, particularly amongst older adults, of the important role that faith and religion play as a coping resource. I can tell you that that I'm privileged to be currently involved with work here at Baylor, where we have recognized, in order to reach underserved populations within our African American older adult community, that we specifically have developed a program that is emphasizing the opportunity to include religious coping as part of anxiety treatment. This is called the Calmer Life Program. I'm happy to share more information with the reader, I guess with the listener offline, but within the Calmer Life, we are seeing that people who elect to incorporate their faith, and there are tools that allow people to kind of express their preferences around using spiritual coping. This is built into the intervention. So as an example, if you're learning how to do relaxation techniques as part of anxiety treatment, you can build images, religious images into that. Or if you want to create coping statements, which is a common strategy in cognitive behavioral approaches, perhaps those can become worry scriptures that you may have from whatever your kind of book of faith is. So we have seen early positive outcomes for people being able to use religious coping, and there is other evidence around people using religious coping strategies as part of a systematic delivery program. Hopefully that is responsive to what the caller was asking or what the questioner was asking. Beyond that, I do know that faith-based communities are a great setting for outreach in terms of letting people know that these issues are part of broader health.
Yeah, thank you. I guess playing off of that, we have another question about group sessions. Are those effective among older adult populations?
So I'll come at that a couple ways. So one of the things I didn't highlight, but I should have, is that beyond the specialty treatment programs like Healthy Ideas and Pearls, there are other broad wellness. There's evidence for programs like the chronic disease self-management model, sometimes known as the Stanford model, producing improvements in self-reported depressive symptom outcomes from participants. So although that particular program is focusing on chronic health and well-being, chronic health conditions and helping people with well-being overall, and it's not specifically tailored to depression, there is evidence that people who have had depressive symptoms had benefit. Likewise, in a program that was studied in Michigan in a population receiving behavioral health services for depression, they saw improvements in those scores. And there have been programs on a much more limited basis, historically a program called Coping with Depression that was done with caregiving populations. One of the biggest challenges, I think, in group delivery of services to older adults with depression is getting people engaged in the group to begin with. Oftentimes, depression creates withdrawal and avoidance behaviors, and so the opportunity to get people engaged in that work is a challenge. I do know that the Pearls model, which I mentioned very briefly, that uses the problem-solving therapy approach, has been done in a few environments in a group setting, and I believe with positive outcomes, although I haven't actually seen that data.
Oh, excellent. Thank you for that. And are any of the tools you showed able to be integrated into EHR systems?
Excellent question. I think you will find a growing number of EHRs that have the PHQ-9 or some standardized tool for depression incorporated in them, particularly as we all can appreciate, oftentimes records go where money flows, and as we see the things like reimbursement for depression screening through Medicare, I think you'll see more and more platforms using this. I will tell you that if you get on the Impact website, one of the web addresses I put up there, if you just type in Impact Depression, they have information and examples about programs not only that are Medicare reimbursed, but other settings that have built depression screening into their EHR platforms, and obviously that'll increase the uptake of systematic screening, which we know is a great preventive practice.
Yeah, most definitely. And kind of following with the innovation, is telehealth effective or an effective method to screen and treat older adults for mental health issues?
Excellent question. I can tell you that the telemental health reviews overall are showing very good and positive trends. The program that I'm most familiar with has been led by Dr. Namki Choi at University of Texas, where in collaboration with the Austin, Texas Meals on Wheels program, they were effective in doing Skype delivery of problem-solving therapy with older adults in the home environment. And so if you, there are several publications. If you just do a search under Namki Choi in depression, you will come across those. And I think that there is other evidence. The bigger challenge, obviously, with telehealth is making that we have disparity in where technology is available. And so I think that will be the biggest challenge. But in terms of, I think that going against the broader view, oftentimes that older adults can't learn, we've seen evidence, again, amongst the high-risk, low-income, very diverse population of older adult clients in this Meals on Wheels program in Austin that people were able to learn and use technology to get help.
Wow, that's great. I'm going to have to check that out myself. And for home-based services and other care models, how do we engage caregivers in this treatment process?
That's a very important question and can be challenging. So I will say, so within the Healthy Ideas program, we try to work directly with the individual because oftentimes the home-based models are very much around personal empowerment and helping people develop skills. And in order to do that, you oftentimes have to engage that individual directly. That said, it's important to have educational material and to help families know what can be supportive. And so we do have specific written education information to share with family caregivers around their depression, but oftentimes that's a decision that rests with the individual themselves, because not everybody is comfortable in having their low mood and their difficulties shared with other individuals. So it's like other treatment where we have to make sure that we've enrolled their, received their permission. But I think that sometimes de facto people get family involved, or again with their permission maybe get involved. But most of these depression care management models so far have focused more on working with the individual. Some of the caregiver delivery models I think are more focused on engaging family caregivers. But I think this is a key issue, and one of the reasons that doing systematic screening in primary care could be helpful is when you're trying to engage that individual and getting some support, it's having the knowledge that they have a problem to begin with, and being able to work with family around that.
And still focusing on the individual, someone made the comment that are some mental health conditions based on the fact that older adults may lack purpose, and that's why they experience the anxiety or the depression, is because they don't have that purpose anymore, that drive?
Excellent observation. So we know that that loss can be on a lot of levels. Perhaps people no longer have the physical capabilities to do what they once did, and so they aren't able to contribute. I think we particularly have a generation of individuals where work and meaning came from being involved with other people and contributing and making a contribution. And we have oftentimes create a lot of barriers. So unless we can help people accommodate, and one of the things that both Pearls and Healthy Ideas does is working with individuals, trying to help them modify and accommodate to still do some of their past interests. So if I used to be interested in fishing, but I can't go fishing anymore, is there something else I can do that would engage with that? So, but I think purpose is core to our all of our lives, and that is one of the reasons I think we see that social isolation and disengagement is such a risk factor for depression and for anxiety.
Yeah, excellent. Thank you so much for taking out the time to join us today. Thank you to all of our attendees. We don't have any more questions in the queue, so I'll just remind everyone that the recording will be made available after the webinar, as well as the slides, and it will also be posted to our website. So thank you again, Nancy, and we look forward to working with you.
My pleasure. Have a great day and be well, everyone.
All right, bye.
Bye.